Good evening, everybody out there. Tonight we're doing a session. It's on non-IVF treatments for infertility. And so the way we ran last time seemed to be quite successful. We started talking and then people type in questions, and I'm really very happy to to a certain extent, just mainly answer your questions and just go where the questions lead me. But we'll see how it rolls. My name's Dr. David Molloy. I'm a senior clinician with the Queensland Fertility Group. I've been doing IVF since the mid-80s and infertility. Have a multi-dimensional practice in infertility with IVF and a lot of keyhole surgery. I was medical director, the boss of the Queensland Fertility Group until last year, and now I have a more national role with Virtus, where I have a national medical director's job, and rather than just a state one. So I'm very happy to speak to everyone this evening, and we'll see how things go. So one of the key things about non-IVF treatments, about 10 years ago, as IVF pregnancy rates started to improve, there started a movement where we moved away from the traditional investigation and treatment of patients, and just people started just using IVF. So it didn't matter what problem you walked into the office with, you were just offered to be put on an IVF program. And you know, it's a sort of two-way way of doing infertility treatment. One is just to say, well, look, IVF is the cure-all for everything. And the other way is to actually do the more old-fashioned medical way, which is that you actually investigate patients, you try and give them a diagnosis and actually understand why they may not be becoming pregnant as a couple, and then you apply the most appropriate treatments. And there's sorts of two ways of treating people. One is what I sort of call the ladder, which is you start off with the least complex, least invasive, and least expensive treatments for fertility, and then you move up the ladder. And at the top of the ladder, obviously, is IVF, which is the most complex, the most invasive, the most expensive, the most stressful treatment, but for many people can also be the most successful. So it's a decision as to which way you go will be made as a result of the investigations, and also as a result of what people want to do. So there are various factors that might determine that. One of the most important things is age. If you're 28, you've got a lot of positive fertility years up your sleeve. If you decide to have simple treatment and don't get pregnant, then you are not going to really suffer a big penalty if you lose 6 months. If you're 41 and you lose 6 months because you're going totally the wrong directions, that can really be material on your chances of getting pregnant, as those pregnancy rates really reduce from the age of 39 to 42, and then really reduce from 42 to 45. So losing 6 months there is a lot different from losing 6 months when you're 28. In general terms, the causes, the treatment, the definitional times of infertility are around about 6 months for patients who are over 36 or 37. And what we've done is we've remodified the definitions now because of the construct of age. And in general, 12 months of trying if you are under the age of about 36. But these definitions, they're very variable. Like, if somebody comes in and sees you and said, look, I'm only 28 and I've only been trying for 3 months to get pregnant, but I'm really worried because when I was 22, I had a terrible case of chlamydia. I was in hospital on an antibiotic drip for 5 days, and I'm really worried about my fallopian tubes. Or if someone walks in and says, look, I stopped the pill 6 months ago and I haven't seen hide nor hair of a period for 6 months, you don't say, well, look, sorry, you've got to serve a sentence of 12 months before we can speak to you. These people have obvious problems, and the 12-month rule isn't actually very valid. So there's a lot of common sense in terms of what you do in relation to fertility workups. And you've got to individualize your approach to the patient. It's not just a case of pulling a textbook down off the shelf and saying, sorry, this is the definition of something. This is the way that we're going to do it. And we can't sort of alter things for your own individual and personal circumstances. So the workup and testing patients is really important. The broad definitional groups of fertility problems are basically ovulation problems where your ovary may not be working. They can be problems with disease processes like endometriosis. Of course, at least 1 in 4 couples has got a male factor problem where the sperm count might be of some problem, and that's why they're not getting pregnant. So, a semen analysis in the workup is absolutely essential. Those are the 3 biggest groups, but then there are a lot of other things that can cause infertility. Structural problems in the uterus, such as fibroids, uterine abnormalities, abnormalities in the lining of the uterus, tubal obstruction problems. They're way less common than they used to be. Post-infective problems or post-surgical problems with fallopian tubes. Occasionally you find patients who've got, benign and very rarely, thank goodness, malignant ovarian tumours. So all of these things are important. Lifestyle issues can be important, and usually, we do take a fairly good history of lifestyle issues. The sorts of things that patients may be doing. Smoking is an absolute no-no. I mean, pregnancy rates are much lower in smokers, and of course, smoking can harm your baby. So we always tell patients, hey, give up smoking, 1, to get pregnant, but when you finally do get pregnant, to protect your baby. Weight's important, and certainly if you're too thin or you're too obese, then you will have much lower pregnancy rates. Obesity is, of course, associated with ovulation problems. Why is that? The fat acts as a mini hormone factory. So when you are quite fat, you convert steroid to estrogen. So you make extra estrogen in your fat tissue. What do you take when you're on the oral contraceptive pill? Well, the combined oral contraceptive pill has got estrogen in it. So what you're doing sometimes, if you're overweight with the fat tissue is like you're manufacturing your own oral contraceptive pill. It goes to the ovary, it can shut the ovary down, just like the oral contraceptive pill does, and you can become anovulatory. And of course, this is the basis and some of the loop. It's not the whole answer to polycystic ovary syndrome, but those patients who are overweight with PCO, one of the treatments, in fact, the only known treatment for polycystic ovary disease, if you're in the group of patients who are overweight with PCO, is to actually lose that weight. And sometimes when patients lose weight, their periods return. And it's the absence of that fat tissue making the estrogen that breaks the cycle of anovulation with PCO, and suddenly the patients start to ovulate. It's an interesting story with PCO, but some people believe that PCO has actually been put in genetically programmed into the genetics of a community, so that you actually have a reservoir of overweight females who don't get pregnant in times of good, but in times of famine, when the whole community is losing weight, then the thin patients who would normally be your reproducers can die, and the fat patients become thin, and the people who were previously obese actually start to ovulate and provide reproduction again for the community. And that's an interesting sociological take on obesity and infertility. So certainly if you're overweight or you're severely underweight and you've lost your periods, we often advise lifestyle advice. Normal exercise is important, mild to certainly no more than moderate alcohol intake, and of course you shouldn't drink actually when you're pregnant. So those are sorts of some of the factors that we work up. And then in the history, the medical history of a patient is very important. We're looking for evidence of cycle abnormalities, cycle regularity, heaviness, painfulness of the periods important. We have a whole string of questions that we ask patients about endometriosis, because of course surgical treatment of endometriosis is a very important alternative to the IVF program. I've had a question here about sperm testing. What would my advice be on a male with a history of varicocele and who's got low count and motility? Varicocele is really difficult. It's so controversial. Even now, my first conference as a fertility specialist back in 1986, I flew to Florence for a specialty male infertility conference. It was the European Andrology Conference. There was a fight, almost a physical fight on the floor with a couple of thousand people on the room, as the urologists and the endocrinologists fought about the value of doing a varicocele operation. That fight's continued for years. In general terms, the studies show that varicocele surgery may increase your sperm count in the presence of a very large varicocele, but does little to improve pregnancy chance. In general terms, if varicoceles are not unsightly or uncomfortable, then by and large, we tend to use, put the patient across more to the IVF program rather than treat the varicocele or treat it with IUI. Obviously, patients can try IUI, but surgery on varicoceles doesn't usually have an association with a higher pregnancy rate, which is the bottom line. Just a question on the side, which is easily answered. Does your AMH decrease more quickly after you have an egg retrieval? No, that's an IVF question. The answer is no, though. When you're born with your eggs, you have a certain number of eggs in your ovary. When you run out of eggs, that's called menopause, and the average age of menopause is 52. When you're 12 years old, the average egg ownership in a young woman is around 400,000. Now, if you think that's 40 years of cycles, that's about 500 cycles in your reproductive lifetime into 400,000 eggs. That's about 800 eggs a month that you use. So what happens at the start of a menstrual cycle is happens at the start of your menstrual cycle is that you start growing 500, 600, 700 eggs on day 1 to 3 of the cycle. Your body then undergoes a process called dominant follicle selection, where you select the egg of the month. So effectively, if you start growing 600 eggs, you waste 599, and just one grows up to be the egg of the month. Now, when we put you on IVF, the way we style our stimulation protocols is that we end up wasting 590 eggs to get 10 instead of 599. So you don't go into menopause more quickly. Your AMH doesn't drop as a result of IVF because you're not using more eggs. You're just wasting fewer of them. Okay, so it's a wastage issue, not a using issue. Another question about whether DHEA helps with fertility. Again, the studies are fairly poor. So there may be some evidence that DHEA helps in patients over the age of 40 and may slightly improve egg count on IVF cycles and may be associated with a slight improvement in egg quality. The jury's out as to whether it has a positive effect on pregnancy chance, and probably doesn't. There's another question about weight loss surgeries causing early menopause and affecting your egg reserve. Absolutely not, not unless the weight loss surgeries, like, it goes really badly wrong. Most weight loss surgery involves removing a section of the stomach and creating a sleeve or stapling a section of the stomach. It shouldn't be going anywhere near your ovaries, and so weight loss surgery shouldn't affect early menopause and shouldn't reduce your egg reserve at all. So we were talking then about history and workup with the idea of moving to non-IVF treatments. So the non-IVF treatments can first of all be ovulation induction. So if you are not ovulating properly, then there are various drugs available, particularly clomiphene, and clomiphene is one of the most widely used drugs. And what we do is we give you 1 or 2 tablets a day for 5 days. Clomiphene is much, much better used in the context of monitored cycles. So there's sort of serious ways to use it, but when you're using a fertility drug, it's much better to use it in a monitored sense where, for example, we're doing blood testing to try and help you ovulate, and pick when you are and pick how well the Clomid's working. Just sort of taking a box of Clomid, taking some tablets, and best guess intercourse at home works much less well and has relatively low pregnancy rates of about 5 to 8% per month. If you do some monitoring, and particularly if you do an IUI, an intrauterine insemination, with your partner's sperm, then you can achieve pregnancy rates of around 10 to 12% per month. So this is a much lower key treatment, but getting the timing right, putting the sperm higher, and using an ovulation drug may be very helpful where you have an ovulation problem. I personally am a little bit more circumspect about using ovulation drugs where the patients have competent regular cycles. What they do tend to do is push the multiple pregnancy rate up a little bit. There is a process called controlled ovarian hyperstimulation, where we give you injections as well as tablets to try and boost the egg number up to 3 or 4. The problem is that has a multiple pregnancy rate of around about 12% per cycle, somewhere between 12 and 14% per treatment cycle or per pregnancy, which these days we're finding unacceptable. The reason we work so hard to avoid multiple pregnancies is the death rate. We did a study in QFG. I did that. We looked at 5 years of outcomes of twins. 1 in 28 twins died after 20 weeks of pregnancy. And because those babies have to be buried and because they didn't die in symmetrical pairs, we found that 1 in 18 families were having a funeral if they had reproductive twins. So we're really trying hard to avoid twins, and therefore when you're using ovulation induction, you try very hard to avoid twins. I've had a patient who said that she has endometriosis and Zoladex for 3 months. Yeah, I think just using 3 months of Zoladex is not very helpful. It's not. I do a lot of endometriosis work. I think just doing a very short term of Zoladex doesn't really kill the endometriosis. It just quietens it down for a very short time, and the rebound off the Zoladex at the end of 12 weeks is quite pronounced. Generally, a course of Zoladex to be really effective needs to be 6 or 7 months. If you don't use Zoladex, then surgery is often better, and then you have a shorter recovery time after surgery and can go into treatment. A patient here say that they've got 4 failed embryo transfers and 1 miscarriage with PGD. Would I think that an immunologist is helpful at this stage? This is one of the great unanswered questions of fertility treatment as to whether there's an immunological cause. Natural killer cells have been doing the rounds now for 15 years, and they cause bitter division. If you thought the fights between urologists about varicocele at meetings were bloody, come to a fertility meeting and discuss natural killer cells. By and large, the case for natural killer cells has not been made. I mean, I've been following the natural killer cell story now for over a decade, and I'm very happy to help patients look at the issues of natural killer cells. We have natural killer cell assays available. I'm very happy to discuss it with patients. But if you look at the valid scientific data for natural killer cells, the case hasn't yet been made for it. Plus, the case has changed a lot in terms of treatments. Still, high-dose steroids seems to be the most likely. I had a long discussion with the reproductive endocrinologist, one of the major pathology companies, about this in recent times, and the competent immunologists are cautious about endorsing things like natural killer cell theory. We do probably think that there might be a case of some cause of immunological rejection of embryos, but realistically we don't know what it is. And we also think that some natural killer cells actually enhance implantation, and suppression of your immune system may not be good. So you need a rejection system for the embryo to implant, you need a level of inflammation, and the theory that probably has credibility is that the more similar your embryos are immunologically to the mother, perhaps the more difficulty there is in implantation, and that you need something like a rejection reaction. You might have heard of when you have, say, a kidney transplant, you're worried about rejection of that kidney, and the patient's go on a whole lot of drugs to suppress that. Well, in fact, we think that rejection reaction to the pregnancy or the embryo that's immunologically different from the mother might actually enhance implantation and improve implantation. So, if you really, really seriously suppress immunological implantation with steroid treatment, then it may not, you may actually do worse things for implantation than you think you're doing. So the natural killer cell, the immunological implantation in relation to the failure of IVF, the jury is still hugely out, and it becomes a matter of belief systems as to which way you go. I've had a question about, is endometriosis surgery recommended for women with very low AMHs? The question really with that is, where's the endometriosis? So patients who've got very low AMHs are really stuck a little bit between a rock and a hard place. If you don't have ovarian endometriosis, but you have otherwise substantial endometriosis in your pelvis, then there's very little risk to operating on that endometriosis, because when you do endometriosis surgery that doesn't involve the ovaries, you don't harm them. So you're not going to affect the patient's AMH, you're not going to affect her lifetime egg supply at all in terms of operating on non-ovarian endometriosis. Now, if the patient has significant endometriomas, that's a lump of endometriosis growing in the ovary, then inevitably when you take that endometrioma out of the ovary at endometriosis surgery, you may hurt some of the ovary and reduce the AMH further. In fact, you probably do, although skilled endometriosis surgeons, I've been doing this for a long time, we take as little ovarian tissue as you can. And it's been very, very clearly shown that when you remove the tissue from the ovary, what you do is you just take the lining of the endometrioma, in other words, the endometriosis tissue, out with as little ovarian tissue as possible. With as little ovarian tissue as possible. And then you probably don't affect the AMH and the egg stocks. The problem is, if you've got big endometriomas in your ovary, it's much more difficult to get pregnant. It really does affect egg quality. It significantly reduces pregnancy rates, and it's a substantial infection risk, because the old blood in the endometriomas, that thick old chocolate fluid that's why they're called chocolate cysts, infects terribly easily. You carry bugs in from the vagina, and with all that old blood, the bugs, have Christmas, they think it's picnic time come, and they, then they can infect old endometriomas so easily, and that can cause ovarian abscesses, which can be life-threatening. So it's a very difficult thing. A patient who's got a large complex cyst, possibly caused by a pregnal injection, that'll almost certainly settle down by itself. If it doesn't, see your doctor. At the very worst, you can actually do like an egg pickup on those cysts and just suck them flat for the patient. It's like a 5-minute anaesthetic, but 9/10 of them will just sort out by themselves if that's the cause of the complex cyst. You have to be careful though. You want to make sure that there isn't some other reason for the complex cyst being present. So we were talking, I think, about ovulation induction and IUI. So when you come to see a fertility doctor, whilst there's a range of things that might be able to be done, there are basically things that you can do before you actually start treatment that still constitute treatment, like surgical treatment of endometriosis, surgical treatment of fibroids. There are various treatments for males who may have lower sperm counts. there are a range of fertility drugs that males can use. We do use clomiphene and letrozole in males. There's a anti-breast cancer treatment that pushes hormones along in males and can makes more sperm. So sometimes you can get sperm counts up off the floor, and a small group of males are making no hormone in the gland in their brain, and you can actually give men the same injections that you give women on the IVF program, those Non-Ivf injections, to actually grow sperm in men as well. So you can give men a 3 to 6 month course. Some of the difficulties of treatment, some of the difficulties of treating males, that it's a long-term treatment. You know, if you're going to give a male a course of hormones, tablets, or injections to try and grow more sperm, it's a 3 to 6 month process. Life cycle of sperm's around about 72 days, so you've got to be going for 3 or 4 months minimum before you get a response to your sperm treatments. Vitamins for males, antioxidants, things like Menopause, been shown to have a minimal effect, but really, you know, my advice on Menopause is, whilst it might be helpful, is don't hold your breath. And of course, there are various surgical treatments for males, and we see a lot of males have had vasectomies, but of course, vasectomy reversal is a viable alternative to IVF. When we do our workups, the terminology often used to patients is, I talk about the choices that they've got. Basically, infertility treatment falls into 3 broad groups. And the way to think about getting pregnant, the way I tell my patients to think about getting pregnant, is that if you don't necessarily have to come to the IVF program, you've got 12 chances a year to get pregnant. That's usually 12 cycles, 12 chances. Each cycle's about 2 days wide, or each chance is about 2 days wide in a cycle. So some of that is timing. There's been some good studies now on those phone apps, and they don't seem to work very well, at least in terms of predicting when you're going to ovulate. But they are useful in terms of just keeping your cycle lengths, and it's got, you know, much better for patients who've been able to track their cycles much better. But as a pregnancy predictor tool about the best time to get pregnant, many of those apps actually are not as good as they claim to be. So what I say to patients is, you know, if you're not needing IVF, you're not wanting IVF, you basically got 3 sets of choices. You're going to get pregnant in 3 places. You know, place 1 is on your bed at home. Place 2 is going to be on the couch in my office where we do IUI treatments. So there's a whole range of things that go around IUI, like whether you use fertility drugs, whether you just do IUI. But they basically produce around about double the pregnancy chance of best guess treatment at home. And then the final choice is that in that 12 cycles is you can have an IVF cycle. And that represents around about the 5 times better pregnancy chance for 30 days of trying. So those are the different choices for people. And within each sub-choice, there's a whole lot of little variations and protocols, how you use the fertility drugs, whether you use IUI, whether you do 1 or 2 IUIs, you know, whether you're using, if you're using donor sperm, do you do IUI for the donor sperm, or do you do IVF to maximize use of your ampoules? You know, what's the most appropriate surgery to do for endometriosis or other uterine abnormalities? If you have tubal blockages, is there a place for surgery there? Tubal ligation reversal still has a place. You know, I cut my teeth surgically on tubal ligation reversal in the mid-80s when we were doing a ton of tubal ligations. Now in Australia, the most common reproductive operation is vasectomy. Australian men are the most vasectomized men in the whole world. For every tubal ligation, there's 4 vasectomies. Everywhere else, there's 4 tubal ligations to 1 vasectomy. There have never been a more henpecked population than Australian males as far as vasectomy is concerned. So it's there are a range of options. I was asked again to comment on the complex cyst. Basically, they mostly settle down, but if it doesn't, you see your doctor, and at the worst, you can actually have those cysts aspirated, the same as doing an IVF egg pickup. So that's a sort of broad-ranging discussion with a lot of question answering on some of the alternatives to IVF. And, I'm supposed to talk for about half an hour now, and we've just sort of run our time around that. If anyone's got any last-minute questions they want to quickly type them in, I'll be terribly happy to take them. Been some lovely messages from patients who represent some really beautiful successes, and it's very nice to hear from some of you like Kylie. And so thanks very much for typing in and joining the forum. It's been lovely to hear from you. If anybody's got any last-minute questions, now's your moment. A patient's asking if you have low AMH and one tube blocked, is IUI worth a try? Look, the answer is, as long as it's genuinely blocked. If it's genuinely blocked, less so. The thing about tubal blockage is how you diagnose it. So if you do just a ultrasound hysterosalpingogram with fluid, either using the ultrasound or sometimes X-rays, the error rate's about 30 or 40%. And a lot of those tubes actually aren't blocked. They're just spasming, or you have differential flow. And so patients are told they've got blocked tubes, but in fact, the answer is that in fact they don't. Now, if you've got a definite history of, chlamydial, gonorrheal infection, proven PID, if you've had a laparoscopy and been shown to have a diseased tube, then that tubal blockage obviously can be real. But single block tubes where they look normal are actually a lot rarer than they've been diagnosed. And I always take ultrasound evidence of fluid not going through the tubes with a grain of salt. But, honestly, if you have a blocked tube and you have a low AMH, you're probably better to get cracking while you've still got some eggs and really look at more effective treatment than IUI. And in terms of opting twins, as I said earlier in the broadcast, avoid twins if you can. I know people like the idea of twins. Enough of them go well, but the death rates are high. And, for those of you who around Brisbane, you would have seen the story on Sunday of a mother who died having twins 2 years ago. And, only a couple of months ago, I saw a patient in my office who'd had 2 embryos back at IVF, and both twins had died at 24 weeks. And she's happily pregnant now. Just done a scan on her, and she's now got an 8-week singleton pregnancy, but she had twins die. And that's a very unhappy thing. You don't want to be going to children's funerals. So we really, really have a big push now about trying to avoid twins because the complication rate and illness rates are so high. And on that happy note, we'll call it a night. Thank you very much for attending. It's been lovely chatting to you. I still find it funny talking to people and seeing the written questions. It's funny not seeing people's faces. But look, have a great night and thank you.